progresses, it can just start from subconjunctival fibrosis in the initial cases, and then it will lead to the shortening of the phonesis and may lead to the formation of symbliphron, or further damage lead to the stem cell deficiency, vascularized corneal opacity, or ultimately it can lead to the dermalization of the cornea surface or maybe ankyloblepharon. So this is how the cicatricial conjunctivitis patients they progress if the inflammation keeps going on. So if you want to categorize the causes of cicatricial conjunctivitis, there are purely ocular causes such as chemical injuries, thermal injuries, drug-induced cicatricial conjunctivitis. They may be because of some infectious conjunctivitis like in post-adenoviral. And the second important category is oculodermal diseases like Stevens-Johnson syndrome, toxic epidermolysis, mucous membrane pemphigoid, and atopic keratoconjunctivitis. The second category is very important. In fact, it constitutes more than 50% of the total cicatricial conjunctivitis patient. Other disorders like ocular rosacea, lichen planus sometimes lead to cicatricial conjunctivitis occasionally. There are some other autoimmune diseases like Sjogren's syndrome, Graf-Slocum disease, they may lead to cicatricial conjunctivitis. So if we see the total epidemiology of cicatricial conjunctivitis, there are only two large studies. One is from US and another is from UK. So these studies reveals that the most common cause stays the mucous membrane pemphigoid, and in the known MMP causes, Stevens-Johnson syndrome, drug-induced cicatricial conjunctivitis, they remain the number 2 and 3 causes. So other causes like lichen planus, Sjogren's syndrome, they also contribute but very less. So if we see typically these all the cases, they looks same if you don't look into the details. So these all are different etiology, but you can see there is a chronic conjunctival congestion, you can see scarring of the cornea, you can see symbliphrons, you can see lid margin changes, lid margin keratinization, keratopathy, stem cell deficiency. So these all kind of changes can be seen in all category of patients, but it is very important to differentiate from each other, because it is very important to diagnose first and then to treat, because each of them have a different root cause and need a different kind of treatment. So if you see the chemical thermal injury, these will have a clear-cut history of insult. So we can just rule out that this category belongs to the post-injury. In case of adenoviral conjunctivitis or allergic conjunctivitis, we can ask careful history and ask the course of the disease, how the disease presented. So again, this category of patient can be identified. So third is like drug-induced cicatricial conjunctivitis. The patient might be using a preservative, tear drops with preservatives or any other kind of anti-glaucoma medications which have preservatives will lead to chronic cicatricial changes. Other rare causes may be graft-versus-host disease or maybe Sjogren's syndrome. But again, the next two common like Stevens-Johnson syndrome and mucous membrane pemphigoid, they are very much similar to each other, and they require a major workup to differentiate from each other. So this is a kind of systemic evaluation if you want to rule out Sjogren's syndrome and other autoimmune kind of diseases. But the challenge lies here, like this is an acute case of Stevens-Johnson syndrome or toxic epidermolysis. The acute cases are not very difficult to differentiate because they will present typically as a oculodermal bullous lesions. So the important thing in the acute presentation is like these patients present with the necrolysis of epidermis, acute inflammation of the lid structures. So we need to cover this inflamed tissue with the amniotic membrane with the help of symbliphron, and we can do such type of suturing and put AMT so that this acute changes doesn't progress to chronic changes. But once the patient has already progressed to chronic changes, there will be a lot of lid changes which will lead to the lid related keratopathy, and the patient might land up into the epithelial defects, maybe corneal ulcer, maybe keratinized or maybe dermalized surface. So our target is to take the possibility of window in the initial phase, but if it is not done, then still the war is not lost. In the chronic phase, we need to change the unhealthy lid margin with the Helgi. So we can just replace with the mucous membrane graft. So this is one of the patient like presented in chronic phase. We did mucous membrane grafting using contact lens, and patient is doing good. So now if you want to differentiate SJS and non-SJS causes, there is a very good cicatricial conjunctivitis score described by Dr. Samra Sanbag and her team. This scoring system take care of medical history points and clinical examiner points, and if the score comes more than 5, it is almost definitive of Stevens-Johnson syndrome, and if the score comes less than 5, it is more towards like non-Stevens-Johnson syndrome causes. So this is very practically useful cicatricial conjunctivitis score I am using in most of my patients. So if like the score is like 0 or 1, it is very less away from 5, then the you have to focus on the causes which are known as yes, like drug-induced cicatricial conjunctivitis, or maybe mucous membrane pemphigoid, or maybe lichen planus, or you have to think of other causes. So these photographs suggest that the burden of the disease in the inferior fornix and the nasal part of the fornix. So this is a typical case of drug-induced cicatricial conjunctivitis, where you can see there is a zipper-like simpliform formation in the right picture. So if you take care of the details of the area of scarring, you can find out the drug-induced cicatricial conjunctivitis. So coming to the mucous membrane pemphigoid, it is again autoimmune disease, and which can lead to the involvement of mucosa anywhere in the body, including the conjunctiva. And if you don't target the disease in the early state, that will lead to the permanent changes. So here come the need of the conjunctival biopsy. So when should we do the biopsy? Suppose you have applied a scoring system. Now the score is very less. We have almost practically ruled out Steven-Johnson syndrome. So we should take biopsy, and this is a technique which is described in literature. So we should take conjunctival biopsy of size 2 into 4 millimeter, and we should send these conjunctival biopsy tissues into two samples, like one for routine histopathological examination and another for immunohistochemistry. So it's very important that we should not disturb the epithelium of the conjunctiva. We should gently hold the conjunctiva tissue, divide it into two, and send for the examination. The area selected should be away from the limbus. It should not have a scarring, because if you take conjunctiva sample from the scarred area, it will not give positive results. Again, if both eyes are involved, you should take sample from the less involved eyes. So this is the immunohistochemistry results from the oral mucosa as well as conjunctiva. So the routine histopathology is important to send, because sometimes you come across different kind of diagnosis, like lichen planus in this case. So we could, due to time constraints, I will not go into the details, but I want to highlight that generally OCP has been described in the classical age group of 60 to 90 years of age, but we have seen patients who have presented as early as 13 years of age. So we have described a case series of young patients only. So we have find out 7 patients in last 2 years. So they are all young patients less than 30 of age, and they are all were diagnosed with the OCP. So take out point from my presentation is to making a definitive diagnosis of cicatricial conjunctivitis can be challenging. Detailed history of the course of the disease provide useful clues. Focused ocular examination for telltale signs and systemic evaluation aid in diagnosis. Cicatricial conjunctivitis score is useful for making an early working diagnosis. Proper timing and technique of conjunctival or mucosal biopsy is of utmost importance in diagnosis. Thank you.
Thank you, Dr. Jitendra. I think that was a very good presentation. And could you just very quickly tell what are your indications for doing a corneal conjunctival biopsy? Because I think that determines a lot about how this patient is going to proceed. So when would you like to subject a patient take up in the OR for conjunctival biopsy?
Yes, sir. Whenever a patient of cicatricial conjunctivitis presents to me, I will take the detailed history, and I will do a scoring system. So if the score comes more than 5, I will just and I am confirmed that the points in the history are very much sure of SJS, like the patient says, I have taken some drug, or I had some fever, and after that I developed skin or the mucosa. Then it's clearly indicate that there was some SJS episode the patient might had. But if the patient doesn't have any significant history of acute onset of conjunctivitis, and there are few other points, like the patient point out that I have oral mucosal ulcers, or maybe other kind of ulceration in the nasal mucosa or on the other genitalia, then it becomes pertinent to send the conjunctival biopsy.
So basically what you're saying is that you use the cicatrizing score.
Yeah.
And once you have the score which is pointing towards something which is non-SJS,
Yeah.
you would like to subject that patient.
True.
Thank you.
Thank you, sir.
I think in patients where there is a high suspicion of OCP clinically, what would be your take on a negative biopsy report, both Dr. Radhika and Dr. Amit?
So negative biopsy rules in, but it does not rule out. So basically the biopsy rules in if it's positive, it's negative, you go by your clinical impression. Because as he said, sometimes it is because of the extensive disease process and the scarring that it may not show up. So it's not 100% positive in all cases of OCP.
Ma'am, do you repeat a biopsy? I mean, in case you're
No,
in doubt,
already the,
or we do
I-
the oral mucosal biopsies, which are easier to do, or something
one
like
can
that?
do, but you know, the clinical diagnosis is quite clear, and then you can give the treatment, because unnecessarily taking more and more tissue from a already scarred fornix may not be advisable. Oral mucosal also you can do, but it depends.
Correct.
Yeah.
And just a question, just a comment that when we are taking a biopsy, you have to process the tissue very carefully, and there are certain guidelines for it. So we won't, like Jitendra, would you like to just quickly say that how do you handle the tissue once it comes, and how do you communicate with the pathologist, and what is the whole procedure that you follow?
So basically, you have to be in very good terms with the histopathologist, and he should be very much interested in doing your biopsies, because most of the pathologists, they are not very much familiar with the handling the small tissues. So first of all, we should take care that while taking the tissue, we should not damage the epithelium, because we want to focus on the epithelium basement membrane junction. And if we have scraped off the epithelium while handling the tissue, then the result will not be positive. So we should hold from one edge of the tissue, and we should cut it, avoiding touching the rest of the epithelium of the conjunctiva. We should gently cut into two. One tissue should be sand in formalin 10%, and other tissue should be sand in Michel's media, which is a transport media, which will let the immune complex stay there at the epithelial basement membrane zone. So they should be processed as soon as early if you are sending it in normal saline. But if you are sending it in the transport media like Michel's media, they can be processed within next 3, 4, 5, 7 days.
Do you transport in ice, or is it okay to transport?
I use in Michel's media, sir. So I don't have any experience
You
of
don't
sending.
have to send it in ice.
Yeah.
That's another advantage. Thank you.
We welcome Dr. Garima Rai. She's going to talk about current concepts and future trends in dry eye syndrome.
Good afternoon, everyone. At the very outset, I would like to thank AIOS for giving me this opportunity to present here today. So my topic today is current concepts and future trends in dry eye syndrome. So as per the 2017 International Dry Eye Workshop DUCE-2 report, so dry eye is now defined as a multifactorial disease of ocular surface, which is characterized by loss of homeostasis of the tear film. And it is accompanied by characteristic symptoms where tear film instability, hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play their major etiological roles. So prevalence in India is estimated to be approximately 35% from the studies reporting 18 to 54%, average 35%. There is usually a very underreported problem. And now according to the tear film report of the DUCE-2, tear film is now described as a complex blend of two-layered structure, consisting first of the lipid layer, which is a mix of a non-polar and polar lipids, and it has a vital role in stabilizing the tear film by reducing the surface tension. Of all the lipids, the polar lipid O-acyl hydroxy fatty acids plays the most important role in the dispersion of lipid layer over the mucoaqueous layer. The mucoaqueous phase is consisting of 4 major types of mucin and approximately more than 1500 proteins and peptides. Of the 4 major mucin, the MUC5AC expression is most important and is usually mostly depressed in all types of dry eye disease. So tear film provides lubrication. It is important for corneal transparency and smooth optical surface, provides the antimicrobial protection, and helps in nutrition and wound healing. So pathophysiology revolves around production of tear film, and tear film is now considered to be produced by LFU, the lacrimal functional unit. It's a very tightly linked integrated system which consists of lacrimal gland, eyelids, the ocular surface, meibomian gland, and net of nerves. And any disease or factor affecting any of these units leads to loss of homeostasis of the tear film. So diagnostic assessment so far has been linked with subjective and objective evaluation. Subjective evaluation deals with taking the symptoms and history of the disease, and there has been various discrepancy in taking it. So to ensure a consistency in recording, the DUCE-2 report said that they recommends various validated questionnaires for symptomatic information. Of these, OSDI, the Ocular Surface Disease Index score, or SANDI, DQ, IDEAL, NVI, VFQ25 or DEQS are most commonly used. Objective evaluation traditionally has been involving the T-BUT, the tear film breakup time, corneal and conjunctival staining, Schirmer's test and tear film assessment, meboscopy and mebography. But latest, very less invasive evaluation techniques are available, starting with tear film osmolarity. So tear film osmolarity is increased in mostly all types of dry eye. Normal osmolarity is considered to be 296 to 302 milliosmoles per liter. In mild to moderate dry eye, it is approximately more than 308 milliosmoles per liter. Moderate to severe dry eye, more than 312 milliosmoles per liter. The osmolarity can be measured by three ways: the freezing point depression method, which is considered the gold standard, vapor pressure method, or electrical conductivity or impedance method, which is considered the most suitable method for clinical evaluation because it requires a very small sample size and very short test duration. Then tear stability has been done usually by the T-BUT, but now non-invasive T-BUT tests are available, which where it can be done by various devices like topography, aberrometry, interferometry, functional visual acuity or confocal microscopy. Here the time, so non-invasive T-BUT is done by observing the reflection from the anterior tear surface of an illuminated grid pattern. So time in seconds from last blink to the first break in the reflected image is recorded. So tear film particle assessment. So this gives a very good, precise and objective evaluation of tear film stability. Here the tear film's upward spread and stability is measured by non-invasive tear film particle speed. So tear film particle speed gives a very good measure of tear film hydrodynamics. So digital images are taken from the center region of the cornea for 10 seconds and they are then fed in the software system to evaluate the speed of the tear film particle. Now recently the topographical systems like topographical system 1 or video keratoscopy is being used to evaluate the surface asymmetry and provide a good evaluation of corneal surface regularity and tear film stability as well. Interferometry, the interference pattern between the colored fringes between light and lipid layer and aqueous layer is used to measure, it gives a very good assessment of the lipid layer thickness. So commercially available interferometer is the LipiView, and it is very useful to observe the nature, thickness and rupture of the lipid layer. It can also be used to perform non-invasive T-BUT test. Aberrometry gives us a non-invasive assessment of the visual disturbance because any amount of tear film instability or breakup induces a higher order abrasion, and this gives rise to reduction in visual acuity and reduced retinal image quality. Then comes the functional visual acuity. So it is an assessment of visual acuity in between the blinks times. So now commercially available continuous visual acuity monitor has come, which records the visual acuity between a 30-second period in between the blinks. OCT, the anterior segment OCT has been used to measure the tear film thickness and tear meniscus parameters, but it can also give us a very good assessment to grade the lid parallel conjunctival folds, lip coughs, gives the 3D maps of epithelial thickness and details of meibomium structures. I'll rush through. The non-contact confocal microscopy, as it gives evaluation detailed structure of all corneal layers and study the inflammatory cells as well. So it gives a non-invasive impression cytology in dry eye management. Then we can go with conjunctival impression cytology and breast cytology also. It gives us the evaluation of epithelial goblets and inflammatory cells. Then management as per the Dew's report, the initial steps could be alteration of the local environment, increase intake of fatty acid, essential fatty acids, omega-3 acids, then elimination of offending systemic and topical drugs, preservative-free eye drops and lid hygiene and warm compress. If these fails, then addition of extra measures like use of punctal plugs, warming and expression devices like LipiFlow, addition of topical corticosteroids and immunomodulators like cyclosporin or tacrolimus. Secretagogues have the new things in the armamentarium like aqueous secretagogues, difosol, lacretine or mucin, ripapamide. or LFA1 antagonist, liftigrast, can be added. Then oral macrolide and tetracycline antibiotics can also be added. If these fail, then third step could be oral addition of oral secretagogues like pilocarpine and cevimeline, autologous serum eye drops, rigid and soft contact lenses. And lastly, for the cases who do not respond to all these measures and who are dealing with complications of dry eye, amniotic membrane graft, surgical punctal occlusion, or surgical approaches like tarsorrhaphy and salivary gland transplantation can be done. Lastly, the few drugs which are under investigation or newer modalities, liftigrast 5%, which is a small molecule integrin LFA1 antagonist, repopamide, which is a quinolone derivative and is a mucin secretagogue, MIMD3 is a nerve growth factor peptidomimetic molecule, which is a mucin secretagogue, daclofosol, which is P2Y2 receptor agonist and helps in mucin and aqueous secretagogue, EB1005, which is a protein-based IL-1 inhibitor, OTX-DP, which is sustained release dexamethasone loaded punctal plugs, RU101, which is a recombinant human serum albumin, LEMMP3 0.5 loteprednol with glucocorticoid receptor agonist, Ocucleave, it's a neurostimulator, it's an intranasal lacrimal stimulator, and then another form of drug delivery system like Ocular ionotrophoresis have been evolved, which is Eagle's Eye System EG427, which is being explored for delivering dexamethasone phosphate solution. So these are my sources. Thank you for your patient listening.
Thank you, Dr. Garima. Very exhaustive topic. You've covered all the important aspects. Maybe a little note about when the autologous serum, in which conditions would you like to give autologous serum? While Dr. Amit is setting up his slides, Dr. Amit will be talking on vector thermal pulsation, current status and challenges. Some guidance as to in which condition you would like to give autologous serum, or any guidance, because that's something unusual, maybe people are not familiar.
They are not responding, there we can go for harvesting, because problem with autologous serum is there could be chances of disease transmission as well. So now umbilical blood flow is being recommended to use where for the testing for infectious diseases has been done, that can be used for.
Ma'am, can I add? I think autologous serum is a wonderful technique for severe dry eye cases. As you mentioned rightly, in those cases where there is absolutely nothing that is working, patient has a bundle of medications, and of course you have to work up the patient for other diseases and etc. And you have to guide them that transmission of diseases to other people who are handling that, but otherwise it works beautifully and a lot of patients get good relief from that. Cold chain has to be maintained, and the patient needs to be educated about maintaining hygiene. So apart from that, it really works well.
So vector thermal pulsation, another variation in the armamentarium that we have for treating ocular surface diseases. Dr. Amit, over to you.
Some adjustment.
इनके बाद नेक्स्ट उनका
I just want to confirm, is Dr. Pragya Panda here? Yeah. Okay. So just check if your talk is ready on that side. Dr. Amit will continue, but just check if it's there.
Ma'am, in routine Sjogren's, do you do salivary gland transplantations? Minor salivary gland transplants?
Not in routine, because because it's a very chronic disease, and sometimes they do well with ribamapide. But otherwise, yes, minor salivary gland transplantation is a good technique. And MSGT for the more severe cases. Minor salivary gland transplantation would be more like a last resort. But otherwise, often ribamapide is a very good option because they do have mucin deficiency. And now we have topical ribavirin, but that came to India a little bit late compared to when it was started in Japan. So we have even given oral ribavirin because that is routinely used by the gastroenterologists. So
So
that
what
can be
would
given for 2 months.
What would be the mix for topical ribavirin?
No, if you have topical, definitely, I'm saying in the transition when we did not have, then we gave topical, then we gave oral. However, topical ribavirin, sometimes people do get a redness with it. So if they are not tolerating it, then you can give them oral, which is very well tolerated. Slight amount of nausea they may have initially, but that's it. For 2 months.
Eye drops, what would you be your preferred other topical agents? Would you give
Apart from
anti-inflammatory?
ribavirin,
Yeah.
yeah. So then I like to give a combination. I like to do a OSA analysis to see what is the extent of meibomian gland dysfunction, which is coincidental. So otherwise, I like to give a combination of carboxymethyl cellulose and sodium hyaluronate because it has a very good water retentive property. If there is a meibomian gland dysfunction, then I like to give one of the lipid preparations. We do have in India now liquid paraffin. Eye ointments of various kinds. Earlier there was only Conny gel. Now Conny gel has gone out, but there is Soft Drops PM and Aqua Lube PMs that are available. No financial
even the
interest in any product.
Evolve XL.
Evolve XL also is a
We give a lot of
liquid
paraffin based. Even I give a lot of paraffin
to
based
use HS.
ointments. Correct. Right. Well.
Thank you, ma'am.
Sorry for the delay. And I'll be talking about vectored thermal pulsation, the current status and challenges. Now, it very nicely complements the last talk and the discussion that we had, that when we are faced with the patient with an MGD, there are so many options, and somehow nothing seems to fit in these patients. And no matter how we try, the doctor ends up frustrated and the patient ends up frustrated. So if you look at just the treatment overview, the traditional things that we are used to giving patients are, a manual expression, or we do the hot compress or external heat application, whereas certain newer modalities are there, one of which I'll be talking about. So with warm compresses, we know that the amount of heat that is required is actually quite challenging to give that kind of an heat, and it ends up heating the cornea ultimately, and the duration is prolonged, and the patients actually can't really do that. And it has to be, it's not accompanied by a gland evacuation component, so it just works partially. When we look at the meibomian gland therapeutic expression, one study found that only 7% of patients could actually tolerate the amount of pressure that is required to completely empty the meibomian glands. So therefore, we are lucky to have a system by which we can have the imaging, we can have the meibomian glands imaging in front of us, the quality of TF film, and so therefore enter LipiView and LipiFlow. So this is a composite unit, a diagnostic component, and it also has a therapeutic component. So diagnostic is called LipiView and therapeutic is called LipiFlow. So this LipiView interferometer, this is a J&J product now by Tier Science, and it was introduced to quantify the lipid layer thickness directly and non-invasively. So it is basically an ocular surface interferometer, and it provides the absolute thickness of the tear film lipid layer. Interestingly, it provides something known as partial blinks, and also gives us the meibomian glands with using near infrared light, and also the ocular surface and eyelids using a white illumination. So this is a typical report. What it looks like gives us a lot of information just at a glance. And then patients who are suitable are subjected to something known as a vectored thermal pulsation, which is the topic of my talk today. So this is an FDA approved thermal device which heats up to 42.5 degrees centigrade for 12 minutes of cycle at the palpable surface of the conjunctiva. And the meibomian glands is extruded by a constant proximal to distal pressure on the meibomian glands, a kind of a milking motion, so that the meibomian glands are emptied. So if we look at the disease cycle, we can understand that normally what happens is there's an increase in oil viscosity, and it leads to the obstruction of the meibomian glands, and that's what causes MGD, and which leads to an unstable lipid layer, too much evaporation, thin aqueous layer, and dry cornea and dry eye. So we do believe that if we can interrupt this cycle, maybe we can benefit the patients in a better way. Why is it important to intervene at the right stage is that, you know, once we have the healthy gland structure, then we go to gland dropouts, and then there's a complete gland truncation and loss. And at that stage, LipiView doesn't really work well. So it's important to intervene at an early time. I talked about partial blinks, but what do partial blinks do? Basically, because of the lack of the muscles being used, there's less force which is secreting the, so it leads to less mebum in the tear film. Also, when the mebum is secreted less out of the meibomian glands, it stagnates and solidifies in the orifices of the glands. And a long time obstruction will then use to a disuse atrophy and ultimate present to us as gland dropouts. So that is how important this is. I think we have to really work on this more when we are treating these patients. So does it really work? What does the literature say? What do other studies say? So one study reported that a single 12-minute cycle of vectored thermal pulsation was more efficacious than traditional warm compresses in patients either in an objective or subjective measurements in treating dry eye with MGD. And most interestingly, there is a couple of publications which have actually reported that the structure of meibomian glands has improved after performing the thermal pulsation therapy in these patients. So this is remarkable, and this is from that study only, and you can see that how the area of the meibomian glands has improved. Other number of studies have shown that in some way vectored thermal pulsation helps us, but who to consider for doing LipiFlow? So it works better in obstructive rather than hyposecretory MGD. So we should try to classify that. It is less effective in very old people, and also patients should have a significant dry eye symptoms. So we can score by whatever means. In the last study talk it has been pointed various questionnaires, or speed questionnaire for example of more than 8, breakup time of less than 5 seconds. Important is dropout area of the meibomian glands less than half of gland imaging, and a lipid layer thickness of less than 60 nanometer. The contraindications are also very important in these patients. Avoid burnt out MGD with lid fibrosis and extensive gland dropouts, because there's just nothing to work on for the LipiFlow. And also eyelid abnormalities or inflammation or any kind of recent surgery or any ocular surface abnormality potentially which compromises the corneal integrity amongst other things. So can we improve the outcomes of LipiFlow for MGD? And we did a study, would the outcomes improve if the patients were subjected to omega-3 fatty acids prior to LipiFlow? Now, what was the hypothesis? The hypothesis is that omega-3 fatty acids may potentially lower the melting point of meibomian lipids, thereby decreasing their fluidity and secretion. So other mechanisms are also involved. So this was a very small study on 45 patients. So we had patients with only omega-3 fatty acids, patients with only vectored thermal pulsation, and patients who got omega-3 fatty acid for 6 weeks and then underwent the vector thermal pulsation. All was analyzed at 12 weeks or 3 months, right? So lipid layer thickness significantly improved in all the groups, little bit more in the combined group, and there was a statistically significant increase in the lipid layer thickness between the omega-3 group versus omega-3 plus vector thermal pulsation group. The speed score improved in all the groups, and they showed a significant improvement. And the group where participants were subjected to vector thermal pulsation reported greater improvement in their symptoms compared to omega-3 group. So they showed that vector thermal pulsation was more successful in alleviating symptoms of these patients. We did MIMO score. So omega-3 with vector thermal pulsation had significantly better improvement between baseline and second follow-up, and omega-3 plus vector thermal pulsation group performed better than other groups when it came to MIBO score. Now MIBO score involves the analysis of meibomian gland orifice plugging as well as the quality of mebum. Other parameters like breakup time and Shermer's 2, partial blink lid and meibomian gland area, there was an improvement in TBUT and Shermer's, but it was not statistically significant between the 3 groups, right? So just some examples showing that how the lipid layer thickness has increased. And at the end, just some precautions that we should interpret the results of LipiView wisely and not blindly. there are so many things which can interfere with the proper reading when it comes to the lipid layer thickness. As much patient rubs the eye before the test is done, and you're going to get a fallacious test. Also avoid oil-based drops, ointments sometime before you do, preferably 12 to 24 hours. Removal of contact lenses, avoiding use of oil-based facial cosmetics around the eye. Simple thing like swimming in a chlorinated pool can interfere with the lipid layer thickness analysis, and any other ocular condition that affects the stability of the tear film affects the assessment of this disease. Thank you very much.
Thank you so much, Amit. That was a very nice overview of the thing, and also you gave your practical experience and scientific results of the study, so that was very good. And how is the uptake of the patients in terms of the lippy flow? Do they have to come back for repeated sessions? What would you generally recommend as a practical point?
There's a cost involved, madam, and therefore I don't like to repeat lippy flow. And unless the patient comes back and says that, listen, I was really happy the first 2-3 months, and doctor, I'm going back. There's a psychological thing attached to getting a lippy flow done. People like it, nice warm sensation for 12 minutes, and they feel that something very significant has been done. Vis-a-vis, say, giving omega-3 fatty acids and drugs, there's poor compliance, very difficult to put all the time, and gastritis, things like. So there's the distinct advantages to having a single point treatment for MGD. I think that's the biggest benefit, and therefore you're not bothered about compliance so much. You do have to continue other medications, but I guess there is I'm more and more believing now that there is a distinct place of vectored thermal pulsation in these patients. We should not let cost come in the way.
Sure.
And I think cost of artificial tears is so much anyway. So if we can decrease that, patients save that over a period of time.
Yeah, that's true. Good. Thank you so much. So we go ahead with talk by Dr. Pragnya Panda, stem cells in ophthalmology.
Respected dignitaries on the dais, off the dais, and delegates. I'll be discussing basically about what are the scopes of stem cell research in ophthalmology. Now, what is to start with? What is a stem cell? It's a undifferentiated cell of multicellular organism which is capable of giving rise to indefinitely more cells of the same type from which certain other kinds of cells arise by differentiation. Now, from a single cell, it can replicate itself and it can differentiate into cells of the same type or differentiate into many other types of cells. The major characteristics of stem cells are self-renewal, clonality, and potency. Now, self-renewal is the ability to go through numerous cycles of the cell division while maintaining the undifferentiated stage. Now, potency is the capacity to differentiate into specialized cell types. In the strictest sense, this requires stem cells to be either totipotent or pluripotent to be able to give rise to any mature cell types. So, a stem cell can divide into one mother cell that is identical to the original stem cell and another daughter cell which is to be differentiated. So, one stem cell develops into, or it can develop into, two daughter cells, and another stem cell undergoes mitosis and produces two stem cells identical to the origin. By this way, the maintenance of the stem cells in the eye is maintained. Now, there are various types of stem cells based on the differentiation potential. It can be a totipotent cell, pluripotent cell, multipotent cell, oligopotent cell, and unipotent cell. Now, what is a totipotent? The ability to differentiate into all possible cell types. Example, the zygote are the first few cells which are formed by the division of zygote. Pluripotent stem cells is the ability to differentiate into almost all the cell types. Of example, embryonic stem cells. Now, multipotent stem cells, these are the hemopoietic stem cells that become RBC, WBC, and platelets. Oligopotent stem cells, these are the lymphoid stem cells, and unipotent are the adult nerve stem cells. So, these are the various stem cells, embryonic stem cells obtained from the inner cell mass of the blastocyst. Now, based on the origin, it can be embryonic epiblast stem cells, embryonic fetal adult stem cells, and important of all these is a induced pluripotent stem cells, which has a very high clinical importance. Now, these are some of the multipotent adult stem cells. It's an undifferentiated cell found among the other tissues than in the ocular tissues. Now, what is a induced pluripotent stem cells? These are the type of pluripotent stem cells that are artificially derived from non-pluripotent cells, typically in adult somatic cells, by inducing forced expression of certain genes or reprogramming the cells for desired gene expression. Reprogramming techniques are somatic cell nuclear transfer, infusion of chromosome extract of the existing desired pluripotent cells, viral vectors, and cell fusion technique. So, reprogramming cells are somatic cell nuclear transfer. So, this technique, by this techniques, induced pluripotent stem cells are produced. Now, what are the stem cells derived from eye? There are retinal stem cells. Human eye contains about 10,000 retinal stem cells. They can be isolated from the eye bank eyes, or even after the elderly patients. They do not differentiate to form brain cells, yet capable of forming all types of retinal stem cells types. Retinal stem cells usually do not require any growth factor and can grow easily and rapidly, even in completely defined serum-free media. Cells can also be isolated from fetal retina. There are limbal stem cells. Since the corneal epithelium must provide a transparent medium for vision, it is devoid of pigmentation and has a smooth stromal epithelial junctional structure. As such, corneal epithelial cells are vulnerable to shearing injury because of their poor adhesion to the underlying stroma. The stem cells in the body are usually located in the deeper tissue layers, presumably for protection. The anatomical structure of the limbus is significantly different from adjacent cornea because it need not be transparent, and these are the places where the stem cells, limbal stem cells, are well protected. It is well suited to harbor and protect the corneal stem cell population. The limbal epithelium 8 to 10 layers thick as compared with the 5 layers in the corneal epithelium. The limbus tends to be heavily pigmented, especially in pigmented races. This may protect the basal cells from carcinogenic effect of ultraviolet radiation. In addition, the palisades of Vogts have an undulating epithelial stromal junction which provides greater adhesion properties, thereby rendering the limbal epithelium resistant to shearing forces. The stromal component of the limbus is well innervated and it is supplied by rich vascular network, allowing regulation of limbal stem cell growth and proliferation through various cytokines pathways. Okay, I'll be rushing through. There are conjunctival stem cells also. They are likely to be scattered throughout the various regions of the conjunctiva: bulbar conjunctiva, pharyngeal conjunctiva, and palpebral conjunctiva. The fornix is well suited to the house and protect the conjunctival stem cell population from extrinsic injury, as it is well located within the upper and lower recesses created by closely opposed eyelids. So, we need stem cell therapy over keratoplasty. If the lesion is confined to the center of the cornea, then keratoplasty is sufficient. But the lesion, if it is confined to the periphery of the cornea, then stem cell therapy is a better option. It can be autologous or allogenic, and X plus Y is equal to Z, where X is the anterior migration of the cells, Y is centripetal migration of the peripheral cells, Z is the number of cells from the surface. Currently, retinal and optic nerve degenerative diseases have limited therapeutic options. The possibility of stem cell mediated regenerative treatment brings renewed hope to the physicians and the patients. Retina and optic nerve are surgically accessible compared to central nervous system. So, diseases which fall into this category are age-related macular degeneration, retinitis pigmentosa, and retinal dystrophies like Stargardt's disease, Best's disease, Leber's congenital disease. So, and certain cases of pterygium. It is believed that cell transplantation in the human retina has the potential to restore the lost vision and provide treatment for advanced stages of retinal degeneration featuring significant. Stem cell and ganglion cell replacement may be possible in near future from induced pluripotent stem cells. Major problem is the reconnection with the donor cells. So delivering the stem cells can be in the intravitreal route or the subretinal route. So inflammatory disease of the lacrimal gland and meibomian gland can also lead to tissue destruction and dry eye ocular surface disorder. Research studies show that both the glands are capable of repair. Multidisciplinary stem cell research has provided wealth of information on the behavior of pluripotent stem cells in the past decades. New technologies have evolved. It can be used for stem cell based on therapy for chronic diseases. However, lot of research is required to deliver the therapeutic modalities so that it can become commercially available. It remains as an incredible challenge for clinicians, scientists and industry leaders. Advanced facilities, well-funded programs and training scientists, standardizing protocols and techniques to assure the quality control should be available. So although preliminary results have been achieved on many different fronts and applying stem cell technology to the eye disease, a tremendous amount of work remains. Some of the main issues are identification of optimal precursor of cell types, establishment of the growth and differentiation condition that meet the safety and effective norms, and manipulation of the surrounding environment to transplanted cells to survive and function. Thank you for your facility.
Thank you, Dr. Pragya. Any questions for the speaker? And in the meantime, I would like to invite Professor Radhika Tandon, and she has a lot of experience in ocular surface reconstruction, and I think she's worked with the best people in the world, and we are looking forward to your talk, madam. Evidence-based approach to ocular surface reconstruction, practicalities and esoterity.
Thank you, Dr. Amit. I'm very grateful to AIOS to giving me the opportunity to present here. And Dr. Pragya, you have nicely covered the baseline information for my talk. So when I say balancing practicalities and esotericy, I just want to highlight some real life situations where something may be an ideal situation, but we have to see according to the patient in front of you and the circumstances. So I'm just, as you all know, that there are various etiologies of limbal stem cell deficiency. The diagnosis is largely clinical. And additional investigations may be done in certain situations. Apart from this, you also need to take into account what is the patient's level of discomfort, vision, age, lifestyle, and so on. So these are the key features where you have this vascularization or pacification, disruption of the palisades of Vogt. Important is to notice whether there is an active inflammation or not. If there is an active inflammation, it's very important to take care of that, because that is going to sometimes improve the situation enough as it is. Otherwise, if you do any procedure and there's active inflammation, is going to limit the outcomes. For impression cytology, again, it's not essential. I just want to mention impression cytology, that what I'm talking, and over the years and over the decades, whatever work has been done, it's with the help of impression cytology that the protocols have been established and the treatments have been validated. It's not that for your patient you have to get the impression cytology done, but just to show that these are the various ways. And as somebody mentioned, it is difficult to get a pathologist to look at the immunohistochemistry. Similarly, for impression cytology also, it's quite tedious, because you have to mark, and then they have to know which side it is, exactly nasal, temporal, which eye, etc. So it is a bit of a tedious process and may not be routinely required. You have to see whether it's unilateral, bilateral, partial or total, and don't forget the vision, because the eye may look quite severely involved, but the level of vision may be different. Look at the extent, of conjunctival involvement, whether it's inflamed or not, and what is the underlying disease. One thing I would say, as I mentioned, control of the inflammation. The other is also the routine use of lubricants and taking care of the systemic risk factors. That itself may sometimes improve the situation. You just require patience and time. So watch the patient for 3 to 6 months, sometimes even up to a year, and they may improve on their own. Also, because as Madam said, that there are pluripotent stem cells in the body. and therefore they may have if there is a partial deficiency, they may again repopulate the limbus and may indigenously re-energize the limbus. And of course, if nothing works, you can go ahead for restoration of limbal stem cells. Don't forget to look for glaucoma, because a lot of these patients have an associated inflammatory process involving the limbus. They may have glaucoma, and in the process of waiting, it should not be they become no PL because of irreversible damage to the optic nerve. So simple principles: make sure that the ocular surface is healthy, because if you have an absolutely dry ocular surface or no tears, then whatever cells you transplant or whatever tissue you transplant is not going to be effective. This is a broad algorithm, unilateral or bilateral, and largely we like autologous because apart from disease transmission, you do not have to give very heavy immunosuppression. But the challenge is in bilateral cases that you do have to go for allografts, and then you have to use measures to control the autoimmune rejections. So a simple thing like a conjunctival limbal autograft, which we are very familiar with for pterygium. Pterygium is in fact supposed to be a focal limbal stem cell deficiency. This technique can be useful. You may use adjuvant amniotic membrane transplantation. We can use in certain bilateral cases, you can use a living related transplant, taking from a near relative like the parent, the child, or brother or sister. But you do have to use immunosuppression in such cases. However, with immunosuppression, over the years we come to realize that topical tacrolimus applied on the upper lid is a very effective immunosuppressive agent rather than going for oral mycophenolate mofetil. I'll just come to that later on. So clinical results with live related, with meticulous care, close follow-up and a titration of medication, you can get good results. This is of course for the bilateral cases. The unilateral cases you will use an autologous. So these are examples of live related allografts, and here again the periphery may not look very healthy, but what you're looking at is basically the center of the cornea, that it should become clear, transparent, and the vision should be restored. Don't forget the benefit of cadaveric stem cell graft, a simple keratolimbal allograft with a donor lenticule, particularly if you have a young donor less than 40 years and fresh. So if this is what is available for a bilateral case, please go ahead and use it. And nowadays it's not so tedious because we do have fibrin glue. Earlier it was very tedious to suture it, but with fibrin glue you can apply it on the bed and just apply a few 10-0 nylon sutures. So these are few examples of cadaveric limbal stem cell transplant. This is a cadaveric keratolimbal allograft, and I think we have Charuta speaking on it, so I will skip over this. But generally, from the point of view of the expense of the immunosuppression and the requirement for the immunosuppression and side effects, generally one would prefer a live related to a cadaveric. Because at least some of the antigens and all are shared. These are example of 6 months of live related versus cadaveric. And generally the general story I want to share with you is everything works. You have to use your own judgment and what is best for that patient, and make sure you take care of the common precautions. Large diameter lamellar keratoplasty is another modality of a cadaveric limbal stem cell transplant. This you would use when there is a marked corneal thinning, because otherwise when you remove the pannus in some of the patients, the residual cornea is very thin and it is going to melt. So in this case, with one shot you can do a large lamellar keratoplasty, including the limbal stem cells of the donor. So this is an example of that. It can do well, but again, of course, you have to use systemic immunosuppression. There are some of the results of a large LK. So the only indication I will say is if it's an unstable cornea, a thin cornea, and it is a situation that you would like to do it together, restore the vision as well. And of course, if this phase and later on, you can always do a optical keratoplasty for the central cornea later on. Cultured limbal stem cells was popular initially. However, now that we have the SLET procedure, it has largely replaced the use of cultured limbal stem cells. But this helped us in the journey to know that this is a system which works. The benefit being you take only a small piece and not taking a very large area of the limbus. This is an example of journey from bench to bedside in an Indian setup, how using whatever local available adaptive methods, growing it on amniotic membrane instead of suspension culture is one example. And then we can look at the donor side, because sometimes there is a concern, particularly live related, Or sometimes even the parents are worried because a lot of children in our country come with the tuna packet injuries and they are worried about touching of the other eye. So you can tell them with confidence that it takes time, but within 6 months to a year, the donor site heals. So here again, quickly, post-op care. This is what I meant about systemic immunosuppression. This is serious immunosuppression. If you do allograft, it requires 3 levels of drugs: a steroid, a lymphocyte inhibitor, which is cyclosporin, and an antimetabolite such as azathioprine. And now we have mycophenolate as an option, and tacrolimus can also be used. Causes for failure, look at the causes, any local compliance with medications, etc. So long-term success, again, it varies. If you look at it, if you look at the systematic review, it indicated there's an absence of RCTs. So generally, largely they are retrospective series or some few prospective series. We did a systematic review of our own, and we found that very, very few RCTs, but looking at the qualitative and quantitative analysis, you see largely the results are similar. So SLET, CLET, and the functional gains, but broadly better with SLET than the others, and that's exactly what we have always come to do with our practical clinical sense, that SLET has largely replaced all the other procedures. However, don't forget that limbal stem cell direct lenticule, this has been missed out in a lot of the studies. And as I said, fibrin glue augments the stability. So we have done an RCT comparing the direct lenticule transplant as well. And there are a few representative images, and here again you see that even direct lenticule is a good option. The benefit there is you're not de-epithelializing the surface, so you're not making the whole area raw, but it takes a little bit longer time to restore itself. And this is an example of a surgical video of how the surgery is done. You will have to be very careful about releasing the adhesions, and beware sometimes under this there can be marked thinning. Of course, with ASOCT we can get some idea. And if there is, you should be ready with a backup tissue, because sometimes there is a perforation underneath and you may have to do a patch graft along with your procedure, and then after you release everything, you have this cultured cells or a SLET, whatever is being done, and then you can get good results with this itself. It takes time, but in the end you can get good results, and it's important to prepare the patient for the fact that it's never going to be restored to the way it was before or like the other eye. The aim is to improve and give some benefit. So the donor site heals, and it takes about 6 to 12 months to replenish. So with that, I'd like to stop here. I'd like to acknowledge the contributions of the stem cell facility, but it's a high-tech involvement. So I'm very glad that now SLET is an option available, so that this procedure is accessible to more people, rather than them all having to go to one center or few centers to get the treatment done. Thank you.
Thank you, madam, for excellent talk and nice videos. And any questions for Dr. Radhika? I think topic has been so well covered, but I think it's so challenging to give that triple regimen of immunosuppression, and a lot of protocols have to be followed, and patients have to be ready to come regularly and follow up with the rheumatologist or whatever team that you are having. Excellent. Thank you.
Ma'am, I have one question. You mentioned direct lenticule transplant.
Yes.
How does that differ from
So the only thing is with the
allografts?
direct lenticule, you are not chopping the tissue and putting it on the amniotic membrane. You are just putting it at the limbus, and then it takes longer. But then it is going to grow slowly. It takes definitely more time, but the benefit there is that you're not removing the whole. Sometimes, you know, you remove all the pannus, etc., and then you put the amniotic membrane, and largely you have very good results with SLET, but sometimes it fails also. So here with the direct lenticule, it is little bit, takes more time, but then you're not removing the entire epithelium from the surface, and this can sometimes be beneficial if you have a partly thin area of the cornea, because if there's a thinning of the cornea, then the amniotic membrane is not enough to sustain. So large LK or direct lenticule are two options you can go, because it's a staged, you have to be a little bit cautious and go have a staged approach. And this direct lenticule can be directly from the autologous tissue, exactly what you would have harvested and chopped and put scattered on the cornea. The same thing you would just put at the limbus. Right? But you have to do superiorly and inferiorly, so you have to take a little bit longer, larger piece.
Wonderful talk and challenging to talk after that. But I'm going to talk about my experience, so I hope this makes sense to as well. So I'm going to talk about techniques, challenges, and long-term outcomes of keratolimbal allograft in limbal stem cell deficiency of non-chemical or thermal injury origin. So, severe ocular surface diseases can result from disruption of stem cells of limbus or conjunctiva, and the disease management depends upon extent of involvement, laterality, severity of the inflammation, presence or absence of symblepharon, tear status, ocular surface keratinization, and systemic factors such as age and general health of the patient. Now, ocular surface severe deficiency of the limbal stem cells or dysfunction of their local microenvironment can be a devastating consequence of diverse pathological insults. Now, once the function of the limbal stem cells is sufficiently diminished, patients can present clinically with various degrees of corneal conjunctivalization, otherwise known as limbal stem cell deficiency. Now, ultimately, development of significant pain and permanently disabling visual loss are the unfortunate results of non-healing epithelial defects, and progressive neovascularization may develop, and severe stromal scarring may also be seen. So, in my practice, apart from from chemical and thermal injury, I see very rarely aniridia or contact lens related keratitis induced limbal stem cell deficiency. More often, I see vernal keratoconjunctivitis, severe cases of Murren's disease, and also xeroderma pigmentosa practically destroying the limbus in both the eyes. So, layer of epithelial cells which is constantly undergoing a cycle of regeneration at the limbus is responsible for multiplication of is being done by the stem cells which are present at the limbus. And indications for keratolimbal allografts per se are bilateral limbal stem cell deficiency, epithelial breakdowns happening despite previous surgeries such as failed autologous limbal transplantations or SLET, and also no live relation actually willing for a transplant because of the extensive counseling that has to be done to the patients regarding the side effects of systemic immunosuppression, and also the risks of limbal stem cell harvesting in the donor itself. So, these are some of the indications in my practice. Characteristics of these transplant is that a new source of epithelium is being given to the deceased surface. It is always a cadaveric donor. The cornea is acting as a carrier for limbal stem cells. As we know, in all the previously described grafts, there is a carrier being there, like a live related conjunctival allograft is the carrier is the conjunctival limbus. And in this case, the cornea is posing as the carrier. Donor epithelial cells are perpetuated within the recipient limbus, and we are actually placing the enemy right into the limbus, which is highly vascularized, containing a lot of antigen presenting cells, thereby necessitating a very aggressive systemic immunosuppression regimen. The advantages are that in previously described literature, 72% attain ocular surface stability. However, these results were short term. Improved visual acuity was seen in 60% cases, and success of subsequent keratoplasty was as high as 46, which is actually very heartening in these severe cases. Now, the techniques, I would like to go back to history. We attribute the Richard Thoft in 1987 to have described this procedure initially, although his procedure was strictly a keratoepithelioplasty and not including the limbus, and wherein after a superficial keratectomy, in the recipient, the donor cornea was covered by epithelium was placed at 4 positions. To harvest these, von Graffe's knife was used to carve the lenticules from the cornea, and the lenticules were consisting of epithelium and just enough stroma to serve as carrier for the epithelium. So, the corneal epithelium serves as a continuous source of epithelialization at the limbus of the. So, you can see at several lenticules that have been placed at the limbus. Now, in 1990, the same group of Thoft published their 13 cases, and in these 13 cases, they had modified the technique and they had included the cornea as well as the limbus, and then they showed that excellent results with good epithelialization and non-recurrence of vascularization. So, Dr. Roswell Feister in 94 added to this experience, and in this the conjunctiva was obtained from the donor, and this was more like a conjunctival limbal allograft than strictly a keratolimbal allograft. Again, he gave similar results with excellent reepithelialization. Subota et al., that is Dr. Jun Shimazaki's group, also described in 1995 their technique in which the corneal rim was cut into two pieces after removal, and then in this case the preserved cornea was used for the first time. So in all the previous cases they were either using the whole globe and which was unpreserved. So they showed these, Dr. Shimazaki's group showed that preserved corneas would work well. And to add to this, Dr. Holland's group now worked on both the techniques together and used both preserved corneal rims and two whole globes for taking the graft. They for the first time established how much of the graft was to be reduced in thickness and how to do it. Several lenticules were placed and almost the entire limbus was covered. Now advances in these were also described by Kenneth Kenyon and Kempik in 96, wherein they used the Moria LSK1 microkeratome and the ALTK system, so that they were able to prepare an eccentric lamellar keratolimbal graft and which was including 3 to 4 cloacas, and unfortunately only 3 to 4 cloacas were available. So Sheffer Seng again described his technique, which is very similar. Mark Manis added to it by because we have to use remnant lenticules, so to make them stable he used needles. And Anthony Aldave in fact described using a pedestal to mount to secure the graft to an acrylic base using cyanoacrylate glue that makes the dissection easy. Marjan Farid described another technique wherein in the slim peripheron area she uses multiple layers of multiple keratolimbal allografts and fashioned them very meticulously in a thin manner to make them just 50% thickness. So these are my this is my first case wherein based on the reports published by Professor Kinoshita in progressive Murren's disease, this patient had very aggressive bilateral Murren's disease in the right eye. We have already performed a 360-degree cyanoacrylate glue application, and then we have done a conjunctival resection also, and still the disease in spite of systemic immunosuppression relentlessly progressed. So as you can see in this image, and then we proceeded to do a keratolimbal allograft as you can see over here, and this is his case 30 months post keratolimbal allograft. The surface is stable, he's had no epithelial breakdowns, and he actually confessed to me that 2 years ago I stopped. He was following up on a yearly basis. On his own he decided that was enough, and he confessed that he had stopped the immunosuppression on his own, not for the side effects but because he felt that it was no longer required. So indications in this case for keratolimbal were progressive pain for the patient, and he was absolutely relieved of the same. At the last follow-up, as I said, there was no progressive corneal neovascularization. The epithelium was very stable, and also the visual gain was quite significant. So we, as Madam mentioned in her talk also, that indigenous restoration of circulating stem cells may have happened. That could be one of the things, or chimeric distribution of donor recipient cells on the cornea were also responsible. So we are not sure, but all's well that ends well. The second case we had was gelatinous droplet-like keratopathy, in which there was recurrence, and this patient was sitting in my OPD like this with a black glass, and despite the black glass was covering his right eye. He had extensive gelatins and a failed graft underneath it. So we went ahead and we did a large graft for him, and this is an intraoperative photograph. Over the large graft we also did a 360-degree peritomy, did the lenticule harvesting from a good donor, and then placed them at 4 sites. Now at the end he had a very stable epithelium, and he's still following up with me almost 2 years post-operatively. Again, indications were recurrent inflammation for the patient, pain, photophobia, corneal vascularization, and the gelatinous deposits. He had unfortunately a failure of the large graft that we placed, and therefore a desec had to be done. However, the epithelium continues to be very stable. Again, not on any systemic immunosuppression, but on a very religiously using topical prednisolone. Encouraged by all these other cases of mine, a lot of patients came to me seeking for some advanced procedure, and therefore emboldened me to do an SJS chronic sequelae in this case. In this case, as you can see, it is an extensively dermalized surface. I did a pannus resection and opened it up and did a penetrating keratoplasty over here. Suddenly the patient decided that an oral mucosal membrane or a minor salivary gland transplant was not a good idea because it might deform his lips, and it threw us off track for the plan of the patient. This patient, despite the keratolimbal allografts, had a little bit of delayed epithelialization, and this is 4 months post-operatively, where you can see the epithelium has now healed. However, the limbal allografts are completely been engulfed by the progressive pannus. We are still trying to counsel him for a minor salivary gland transplantation so that the wetness of the surface improves. We hope that he agrees. Last case I want to share is the most recent one. This is a case of severe VKC. Again, somebody has done a penetrating keratoplasty for him, which is again not visible in this first image, but the graft has failed and we could see it on anterior-segment OCT. And we went ahead, and this is the first post-op day with pannus resection, and then 4 keratolimbal allografts have been placed over here. This is very rapid reepithelialization happened in this case, and this is my third case of VKC where I have done a keratolimbal allograft, and excellent results. And again, whether altering the milieu of the limbus is actually allowing his own limbal stem cells to take over and start functioning is what my hypothesis would be. So these are the results, and we got epithelial breakdown in only the one case of Stevens-Johnson syndrome, and then the remaining cases they've been doing really well. Literature analysis says something else, and more often than not, they fail at 24% fail at 5 or only 24% success rate at 5 years. Ambulatory vision is only 45% at 5 years, and performed poorly. They may lead to worse outcomes. And of course, immunosuppression, there are side effects, there are adverse effects.
Just wind up.
Yes, ma'am. Last slide. Allogenic graft rejection has also been described in these cases, but we have not seen it in our practice. Thank you so much, Dr. Radhika, ma'am. I would be happy to hear your comments on them.
Yeah, very nice results, and very good to see the effort and perseverance that is required in care of such cases. But that point about the patient who had stopped the treatment, I should have also mentioned, what has been shown is that you really need to give the immunosuppression only for 1 year. Because after that, there was a study done by, I forget the name of the first author, but Shiraz Daya from the Blonde McIndoe Center in East Grinstead. So they have done the impression cytology and the DNA fingerprinting of the surface of the cornea. And after 1 year, they had found that it had been replaced by the host DNA. So exactly that, when you improve the ocular surface, slowly the host stem cells then replenish. Yeah, because you improve the milieu and the stem cell niche, it's more healthy, and then slowly. So after, you have to basically give them immunosuppression just for 1 year. And as your patient also, it turned out that it worked out. So thank you everyone. And can we have a group photograph of all the speakers and presenters? Maybe all the attendees can also come, because all of you are committed to this field, so please come for the group photo. Please take a group photo.